Hi, my name is Takashima, and I'm the Program Director of Otolaryngology, Head and Neck Surgery here at Baylor College of Medicine. And I'm also the Director of the Sinus Center at Baylor College of Medicine, and I get the opportunity to talk today about one of my favorite topics, of course, of sinusitis. And so let's go ahead and get started here. So let's take a look at our learning objectives. A couple of things. One, we're going to talk about what exactly the sinuses are. Number two, we're going to talk a little bit about the sinus anatomy, because if you're talking about sinusitis, you really need to know a little bit about the anatomy that we'll be talking about here. In addition to that, I want all of you guys to be able to recognize and treat typical cases of sinusitis. And of course, we all need to know about the potential complications that can occur with untreated or poorly treated sinusitis. And so I'm sure we've all seen a patient such as this, which we quote call the quote trouble patient, where the patient comes in and the patient has a whole slew of different complaints. Mainly, doctor, I have a headache, I have dizziness, I have a sinus, I have a constant lump in my throat, skin rashes, chronic fatigue. And if you really think about all these symptoms that the patient is complaining of, one, of course, it could be allergies, but two, it can really be sinusitis as well. And so, for some of these complex patients where a lot of things are going on, you really have to keep allergies and sinusitis as a potential point in your differential. And so let's move ahead and talk a little bit about what the sinuses are and what do the sinuses actually do. And so if you look at the slide here, you can see that the sinuses imparts resonance to the voice. And so if you have big chambers inside as part of your skull, then that actually will resonate as you talk, and so it can impart resonance. It is also thought to humidify and warm inspired air. And so as you can imagine, the sinuses are big spaces inside your nose and your skull. And so it increases the surface area where the air can be humidified and warmed. In addition to this, it is thought that the sinuses absorb the shock. So if there's any trauma to the head, it sort of protects the brain by serving as almost like shock absorbers or crumple zones. The sinuses are also thought to keep the nasal chambers moist, thermal insulation for the brain. It also contributes to facial growth. It can also represent the vestigial structures. And of course, it is also known to lighten bones of the skull. And so if we didn't have our sinuses, the weight of our head would be significantly more. And this is clearly seen in elephants as well. And so the sinuses, as we all know, are lined with respiratory mucosa. And the respiratory mucosa is comprised of ciliated pseudostratified columnar cells interspersed with goblet mucus cells. The ciliated channels promote the flow of mucus, and so the openings of the sinuses are very particular in that all the cilia are sort of geared towards moving the mucus towards the opening of the sinuses. And that's the reason why, even for the maxillary sinuses, we never really punch holes along the floor of the maxillary sinus. Before we really knew about the function of the cilia, we're always thinking about punching small holes along the floor of the sinus, thinking that the dependent drainage will actually help with that. But what we've realized is that the cilia, even if there is a hole lower down, it does not promote flow of mucus to that lower dependent opening, but instead it will actually uh, channel the mucus directly to the openings, natural openings of the sinuses. And that's the reason why now our philosophy is to dilate the natural opening of the sinuses rather than creating accessory sinus openings. And so as you can see in this slide, especially in this graph here, this sort of shows the flow of mucus from the sinuses. And the majority of the flow of the mucus actually does go posteriorly, although some of the sinuses along the anterior ethmoids, the maxillary sinuses, can also actually come out anteriorly as well. But the sinuses mainly are divided into two groups, the anterior and the posterior groups. And the anterior groups are thought to be the frontal sinuses, the maxillary sinuses, and the anterior ethmoid sinuses. And the posterior group is thought to be the posterior ethmoids, along with the sphenoid sinuses. And because of the way the sinuses drain, especially the posterior component of the sinuses, which tends to to flow posteriorly, you may not actually have anterior rhinorrhea or runny nose, but more postnasal drip complaints. And so let's briefly talk a little bit about the maxillary sinuses, or the largest sinuses that we have, which is located behind the cheeks. They are typically present at birth, but they slowly aerate over time, and they're full size during the teenage years. It occupies the maxilla, and it's about 15 cc's in volume in adults. A couple of clinical aspects to think about in regards to the maxillary sinus is that sometimes you can actually get maxillary sinus disease or recurrent infections of the maxillary sinus if there is a bad tooth, and especially the molars. The upper molars, actually, the roots of the upper molars embed towards the sinuses, and sometimes they actually extend into the sinuses themselves. And so, if you have a periapical abscess of one of the molar roots, you can get chronic sinus infections on that side. But in addition to that, if you also get some dental work done and you get a tooth pulled, or you actually have some dental implants placed, or even a root canal, you need to make sure that that is not penetrating through the mucosa into the maxillary sinus. Because if that is the case and the patient is having recurring sinus disease in that sinus, then clearly further dental work would need to be done, possibly even removing some of the implants and or closing an oral sinus fistula. In addition to that, we also see some variations of the maxillary sinuses, such as septations of the sinuses or duplication of the maxillary sinus. But in addition to that, you can also get hypoplasia of the maxillary sinus, and that's shown in the second picture here. And as you can see, the right side, the patient has a very small maxillary sinus on this side, while a large maxillary sinus on the other, and it could be congenital. It could be something called silent sinus syndrome, where the openings of the maxillary sinus is blocked since childhood, and as the maxillary sinus tries to continue to aerate, it is unable to pull air, and thus it stays small. But in addition to that, if you have bilateral hypoplasias, that's typically seen more commonly in cystic fibrosis patients. Now, the importance of this is that as the sinus, if it stays small, then typically if you're trying to irrigate the sinuses or operate on the sinuses, you really need to realize that the orbit actually drops down a little bit lower than it should with an aerated sinus. So as you can see, an aerated maxillary sinus on the other side, and it sort of props up the orbit, while on this side here it does not. And so as you can imagine, if you're trying to open up this sinus, there's a higher degree of potential injury to the orbit because the orbit is in a much lower position. Now let's move on to the sphenoid sinus. And the sphenoid sinus is located in the center of the head. It's typically absent in approximately 1% of the population. The volume is approximately about 7 to 7.4 centimeters cubed. There is a high variation, and what I mean by variation is that you can have a very prominent sella protruding into the sphenoid sinus, or you can have the septum, which is not in the midline position, or you can have accessory septations in the sphenoid sinus as well. And so it's really important to study the scans to see exactly what you're dealing with, especially if you're thinking about operating into the sphenoid sinus. So here are some depictions of where the sphenoid sinus lies, and as you can see on the first picture here, that's a sagittal cut, and through the sagittal cut you can actually see the entire clivus, which is located here, and the sphenoid sinus is located in this area here, aerating into the clivus. This is actually the sella, and the sella is where the pituitary gland lies. This area is called the tuberculum sella, and this right here is called the planum sphenoidal. And this is actually a coronal cut, so you can see the temporal lobes here, You can see the pituitary gland located right here. You can see optic nerves here, pituitary stalk coming down, cavernous sinus. You see the sphenoid sinus. And lastly, let's talk a little bit about the ethmoid sinuses. The ethmoid sinuses are the most complex of the sinuses in that there are multiple air cells with its own ostium. There's approximately 4 to 17 air cells per side. And the location of it sort of makes it a little tricky in that, as you can see here, the orbital wall is right here. the skull base is up here, and so it's in a very narrow space between the skull base and the orbital wall, and the ethmoid sinuses are located right in between. Okay, so let's talk a little bit about the frontal sinuses. The frontal sinuses are located right here, right above the orbit. So you can see the orbit here, orbit here. These are where the frontal sinuses lie, and this is actually a sagittal cut. And you can sort of see the frontal sinus here. So the brain will be located behind the frontal sinus. And this is the anterior table of the frontal sinus, posterior table of the frontal sinus, floor of the frontal sinus, and this is actually inside the nose, right here. And so the uniqueness of the frontal sinus is that it is located in our forehead. So evaluating the frontal sinus can be difficult. You really need angled scopes, angled instruments to really try to access the area of the frontal sinus. And so I always go through this little graph here, and this, what we're looking at is a coronal cut of a cadaver, painstakingly cut in small slices, and we'll go through the anatomy here as the cuts continue to progress. And so right here, what we're looking at is we're looking at the cartilages of the nose. You can sort of see the septum, nasal septum. You can start seeing the eyes coming right here and here. You can see some slight shadowing of the eyebrows. And of course, the mouth is down here. And so as we keep on visualizing the different cuts, you can see the orbits there. Let's go through that again. All right, so one of the first sinuses that we see here are the frontal sinuses located above the orbits here. These are the ethmoid sinuses between the eyes. This is the middle turbinate. This is the inferior turbinate lower down. You see the infraorbital nerve right here. This is the maxillary sinus. Maxillary sinus on the left right here. The nasal septum is right here. And as we can keep traversing posteriorly, we see the sphenoid sinus as it appeared at the last part of the video. All right, so now that we've gone through the anatomy, let's talk a little bit about allergies versus sinusitis. And this is actually a very difficult concept to really understand and identify, diagnose, and treat. And the reason for that is because allergies and sinus disease can actually present with very similar symptoms. Sometimes it's very difficult to differentiate a bad allergy attack versus having a sinus infection, and vice versa. And so some clues that we use to try to differentiate the two is that with allergies, mainly sneezing, stuffy, runny nose is prevalent. Clear or whitish nasal drip, itchy, watery eyes, and a burning sensation in the eyes or nose. Those are the common symptoms that we see with allergies. And from a sinusitis standpoint, we see fever, pain in the upper teeth, pressure or pain in the upper cheeks, top of the nose, or between the eyes or along the forehead. We also see a stuffy nose, thick yellow, greenish, or grayish mucus drainage. And symptoms typically last greater than 10 to 14 days. Now, in addition to that, what we really need to do is to ensure that we're not seeing other possible pathologies. And one of the other things that you need to keep in the back of your mind, if a patient complains of unilateral nasal drainage, is a CSF leak or a CSF rhinorrhea. And this next video shows this. This was a patient that presented into my clinic with a unilateral rhinorrhea. And when we looked up this patient's nose with endoscopes, this is what we saw. And so as you can see the pulsations of the CSF into the nose. You can actually see that what we're looking at here is the roof of the ethmoid sinus, or the skull base. And clearly this was the cause of the patient's runny nose. So what are some things that we utilize to diagnose if something is either a sinus infection or allergies? And sometimes, like I said, it can be very difficult. And so in those situations where we are having a hard time differentiating the two, we may decide to get some films. Now, we hardly ever get any plain films at this time. Before CT scans, we used to get these Caldwell waters and lateral views of the skull. But as you can see in these pictures, it's very difficult to ascertain what's a shadow, what's a normal shadow versus an abnormal shadow. And frequently we're sort of guessing to see if there is pathology in the sinuses versus having a CAT scan. And so the picture on the left shows a CT scan in the coronal plane. You can see the orbits. You can also see the maxillary sinuses. Black is air, white is bone, gray is soft tissue or inflammation. So the patient does have a little bit of inflammation on the left side, but the majority of the disease process is located on the right side with a lot of thickening inside this patient's maxillary sinus. And nowadays, we're also starting to do more 3D imaging as well, especially for patient understanding and patient informed consent. We've realized that 2D can be very difficult for patients to ascertain exactly what they're looking at, and so the 3D pictures tend to show in much greater detail while keeping the spatial orientation for patients to understand where the eyes are, where the brain lies, where the ears are, as well as the sinus disease. And here's further representation of 3D CTs that we also utilize. Now, what else can we do? Well, we can also do rigid nasal endoscopies. And so these two videos show rigid nasal endoscopies done in our clinic. And, if we're having a hard time differentiating, hey, does this patient have sinus infection, sinus disease? You can take a quick look inside the nose, suction the nose, ensure that there isn't any purulence. As you can see in both of these pictures, there is significant purulence in these patients' sinuses, which we are attempting to culture and clean out. All right, so let's move on to discuss the concept of rhinosinusitis, or also known as sinusitis. Definition is that it is a condition manifested by an inflammatory disorder involving typically the mucous membranes of the nasal cavity, paranasal sinuses, and also you can also have thickening of the bone or osteitis of the bone, which can then cause recurrent sinus disease as well. It is actually a prevalent disorder, in that it is estimated that about 12.5% of the population have this disorder, and it's second only to arthritis in frequency among chronic conditions affecting Americans. Now, if we try to define the the topic of rhinosinusitis to a greater detail, we actually can see that it is defined as acute, subacute, chronic, or recurrent in nature. Acute rhinosinusitis is typically considered to be symptoms lasting for more than 10 days but less than 4 weeks. Subacute is thought to be symptoms lasting 4 to 8 weeks. Chronic sinusitis is symptoms lasting longer than 8 weeks. And recurrent sinusitis is 3 or more acute episodes a year. Allergies is also thought to contribute to rhinosinusitis, in that allergies can cause a lot of swelling inside the nose, and with swelling inside the nose, the openings of the sinuses can get blocked. And when you get blockage of the opening of the sinuses, then you get stasis of mucus, and the mucus can then get infected. And so surgical success is also hinged upon improving allergy symptoms, and thus we really try to address the allergies at the same time as we're addressing chronic rhinosinusitis. One of the difficulties that we encounter is determining if a patient has bacterial versus viral sinusitis. And and there's some tips and tricks that we use to try to differentiate the two. It's not 100%, but it definitely gives us a guideline to go by when we're trying to differentiate the two. And so signs or symptoms which are more favorable for bacterial rather than a viral sinusitis is that after about 5 to 7 days, if the symptoms are continuing to get worse, and if it persists for greater than 10 days, and or if the symptoms are out of proportion to a viral URI, such as a severe pain, uh, facial pain, headaches, unilateral disease, those are all thought to be more bacterial in nature. You can also have unilateral purulent rhinorrhea. The pain can be worsened by bending over or performing a Valsalva maneuver. Patients also typically complain of a lot of teeth pain as well. They can respond poorly to decongestants, and they can also have other sequelae of a bacterial infection, such as facial swelling, conjunctival infection, meningeal, or other signs, which are typically signs of spread outside of the sinuses themselves. So let's talk a little bit about why some people get a viral infection and then all of a sudden get a sinus infection. The way that sort of works is that the viral infection or the upper respiratory infection can then cause mucosal inflammation. Now, if you have a viral infection, but on top of that, you also have other causes of inflammation in the nose, such as allergies, anatomical issues, or even GERD, then that can actually worsen the mucosal inflammation, which then, like we had talked about, can cause the mucus stasis, which then, without the mucus being moved out appropriately, you get obstruction of the opening of the sinuses, which then leads to bacterial colonization and infection. Uh, you can also have a weakened host defense system, which can then lead straight from a viral infection straight to a bacterial colonization and infection as well. And so the reason why it's important to identify a patient with viral versus bacterial sinusitis is because viral upper respiratory infections and viral sinusitis will resolve without antibiotics. If you use antibiotics in this situation, one, you're possibly promoting resistance, but in addition to that, the patients will not improve to any significant degree. In this CT scan here shows a patient with an acute viral upper respiratory infection. And 2 weeks later, without any treatments, you can sort of see the response that the patient has had just with supportive care. So, what is implicated in acute bacterial rhinosinusitis? And as you can see in this chart, really the three main causes that you should remember are strep pneumonia, H. flu, and Moraxella catarrhalis. Those are the three most common bacteria that causes rhinosinusitis. There are other things such as Staph aureus and anaerobes that can also do the same. However, uh, the, just note the three main causes. So let's talk a little bit about the treatment algorithm of an acute rhinosinusitis attack. And so initially, symptomatic therapy, hydration, and observation is appropriate. If the signs and symptoms begin to wane after about 5 to 7 days, then great. The patient probably has just a viral URI, and nothing has to be done other than supportive care. Now, on the other hand, if the signs or symptoms worsen after 5 days or last greater than 10 days, then the patient probably has an acute sinus infection. And for those patients with community acquired infection, if the patient is otherwise healthy, high dose amoxicillin for 7 to 14 days, typically I do 10 days, should be instituted. For those that fail to improve at all within approximately 2 days, we may consider switching the antibiotic to a broad spectrum antibiotic or possibly even a beta lactamase resistant antibiotic for another 10 days. Now, for those patients who are immune compromised or have been recently hospitalized or have chronic conditions, then in that situation, we would actually jump to the broad spectrum or the beta lactamase resistant antibiotics, such as augmentin. And so these are the most common antibiotics that we use for rhinosinusitis. And just make note of the first four. The respiratory quinolones are thought to be effective in 95% of all sinusitis, and that includes Cipro, Levaquin, Avelox. High-dose amoxicillin or high-dose augmentin is also thought to be very highly effective in 94% of the cases. Ceftriaxone is also highly effective along with amoxicillin. As you can see, there are a slew of other antibiotics that can be utilized with sinusitis as well. Now, let's talk a little bit about, now we've already talked about viral, we've already talked about bacterial. Let's talk a little bit about allergic fungal sinusitis. And this isn't an invasive process. Many people here in Houston, especially in a damp climate, will come down with allergic fungal sinusitis. And this is the typical CT scan of a patient with allergic fungal sinusitis. Sinus disease in maxillary sinus. Ethmoid sinus is here, as you can see. It's actually eroding some of the bones of the orbit. It's eroding some of the bones of the skull base. You can just sort of see the entire pathology here, eroding the bones of the sphenoid sinus. Looks like it's going into the pterygoid spaces. And also possible some extension intracranially as well. But keep in mind, this is an allergic process, and it's not an invasive process. So the treatment really resides in steroids, antibiotics, antifungals, as well as surgical clearance of the disease. The reason why antibiotics are frequently used is because frequently the polyps block off the sinuses, and many patients have an active sinus infection, a bacterial sinus infection, along with a fungal sinusitis. So this is sort of what we saw inside the patient. So this is an actual video of that same patient's surgery. And as you can see polyps inside the nose here. We're using a device called an oscillating debrider, which sort of sucks and cuts at the same time. So we're removing the polyps, we're opening up the sinuses, we're removing all the fungal mucin out of the nose. We're looking into the sphenoid sinus now. We're palpating the carotid artery there. Carotid artery on the opposite side. We're removing the sinus disease right there from the pterygoid space. Now, the allergic fungal is completely different from the invasive fungal sinusitis. Invasive fungal sinusitis typically occurs in those who are severely immune compromised or in diabetics who have poorly controlled sugars. And we see patients also who are on a lot of immunosuppressive medications, such as transplant patients as well. Typically, it's a fungal sinusitis with invasion of the fungus into the blood vessels, causing necrosis of the tissues, which then promotes more fungus growth. And so when we look inside of these patients' nostrils, as you can see, you see a lot of necrotic tissue. Normal side is shown on the other side. And as you can see on the CT scan, it really doesn't look that much different from just a regular sinus infection. So you need to have a high suspicion, clinical suspicion, whenever you're consulted on a patient who may be immunocompromised with a possible sinus complaint. So what are some of the surgical treatments for sinusitis? And so like we sort of talked about earlier, just opening up the sinuses, removing the blockage of the sinuses. So this is a view of a polyp inside the patient's nose. And as you can see, the polyp is just blocking all the drainage pathways of the sinuses. And so we're sort of opening up the drainage pathways here. We're removing the pus from inside the maxillary sinus in this situation. Clearing the inflamed tissue, removing the polyps, opening up the sinuses, removing the pus from the sinuses, and we typically will irrigate the sinuses with an antibiotic, and we also will place certain packing, dissolvable packing typically, to prevent any scar tissue from forming as well. Now, we also do a much more minimally invasive techniques as well. Some patients will complain of weather change related headaches, and in that situation, the CT scan may look completely normal. However, the openings of the sinuses may be so small that it's not able to um, maintain the same atmospheric pressure from the environment to the inside of the sinuses. In that situation, all we do is we'll actually place a small little balloon directly into the opening of the sinuses, and this is the sphenoid sinus, which has been dilated with this balloon. And all we do is we dilate the openings of the sinus, pull the balloons out, and that's it. No cutting involved, just dilation. Same technology as cardiac catheterization, and this technique also works very well in a select subset of the patients that we see. Now, briefly, in the last part of our talk, let's talk a little bit about the complications of sinusitis. And so, as you can imagine, because of where the sinuses lie, the complications are typically associated with the structures that lie close to the sinuses that are infected. And so frequently what you can see is infection of the ethmoid sinuses, which can then cause an orbital cellulitis, as seen in this patient. You can also actually get infection from the frontal sinuses that go posteriorly, and you can also get a brain abscess as well. In addition to that, you can see in this coronal cut, you can also see in this axial cut evidence of frontal sinus disease here as well as here, but you can also see that the frontal anterior table is actually eroded from this patient's sinus disease and is actually causing swelling of the patient's forehead here. So this is when actually the anterior table is eroded, and this axial scan shows when the posterior table is eroded, causing a brain abscess. And lastly, if you have sinus infections, typically patients are blowing their nose quite a bit. In some instances, especially if the patient has had previous surgeries inside the nose and or trauma, you can also blow air directly into the orbit as well. And so that is also one thing that you need to be aware of if a patient complains of swelling of the face after blowing the nose, and you feel some crepitance beneath the skin in that area. There is a possibility that the patient is blowing air from the nose up into the sinuses, out of the sinuses into the orbit. And that is all when it comes to sinusitis. If you have any further questions, please feel free to email me at takashim@bcm.edu, and I'll be happy to talk to you further about this interesting topic. Thank you.